Okay, guys. Like we said, that when it comes to preventing the transmission of the virus from the mother to the baby, PMTCT does not start. It starts before the mother conceives. It continues when they actually get pregnant. It continues during delivery. It even continues when the baby is now delivered. So let's talk about now PMTCT post delivery. What happens post delivery? What are the things that we need to do after the baby now has been born? We said that you have this mother. She tests, or she has tested, she's negative. If this mother has been negative throughout, like before conception, during the antenatal period, intrapartum, then this is good. This mother, she just needs counseling how to prevent her getting the virus. Is to counsel her to remain HIV negative. But when you come to the other side, now the mother is positive. And we did explain that because the mother is positive, the baby is said to be HIV exposed. Not HIV positive, but the baby is HIV exposed. HIV exposed. So a HIV exposed baby is classified into low risk or high risk. A high risk infant or a low risk infant. I think I did explain this on my video, but let me explain them again. A high risk infant is an infant whose mother has got a viral load of more than 1,000 copies per mil. Sorry about this. That's the first. The second thing, a high-risk infant is an infant born to a mother whose VL is unknown. So this VL of more than 1,000 should be within 12 weeks. But if there's no VL that has been done in the past 3 months, then that mother has got an unknown VL, and because of that, she's a high risk. The baby is a high risk. Another high risk is someone who has defaulted treatment. There are those mothers that you're gonna find, they come in, but when we talk about this, actually we're talking about the same thing here. It's gonna be that person who comes in, they've defaulted treatment, but they come in, they're here to deliver, and then they tell you that actually I am HIV positive, but I've not been taking treatment for the past whatever period. So, and there's no VL that has been done in the past 3 months. So because of that, they have got an unknown VL. Another person who is a high risk is that person who comes in and then they are found to be positive, to be HIV positive intrapartum. Right? That's a high risk. And the reason why it's very important to know these things is because, like we said, that the treatment of this infant has got to be dual. When we say dual, we mean 2 drugs, and the drugs that are used at this point, I mean, as we all know, guidelines, they change, but MVP and AZT are the drugs that are used at this point. A low risk infant, VL, that is less than 1,000, and that has been done within 12 weeks. Mother has been on ART for a long time. So that's a low risk infant. Then those ones are put on mono therapy, and it's MVP that they are put on. How long should these patients, how long should these babies be on treatment? Okay guys, so the next big question to answer is, how long should these babies be on prophylaxis? They are not put on prophylaxis forever, guys. Ne? And also, how often should they test? So we said high risk. We already know what high risk is now. If in a test they ask you what criteria must an infant meet in order for them to be labeled as low risk or high risk, we're gonna get full marks there. Now for a high risk infant, let's talk about feeding first. Let's talk about feeding. The method of feeding can either be exclusive or mixed. Exclusive feeding can be breast, milk or breastfeeding, or it can be formula. When it comes to how long the infant is gonna take the prophylaxis, it depends on the method of feeding. It depends on whether it's a low risk or a high risk, and also it depends on the method of feeding that the infant will be put on. Mixed feeding is not recommended, meaning today they are breast, tomorrow they are, or even in one day, while they are on breastfeeding, they are also formula feeding. While they are formula feeding, they are also breastfeeding. That's mixed feeding. It's not recommended. Remember, people have got rights, so our job is to give people information and then they make a decision from there. There's no one that should be forced to either breastfeed or either to mix feed, or I mean, everyone has got a choice. Our job is to give people the information and then counsel them and explain everything, and obviously with the hope that they will come this side, because when it comes to PMTCT, we want them to be either formula feeding exclusively or breastfeeding exclusively. I don't know if I have said this before, but in around 2010, 2007, around that time, I think, let me just say before 2010, 2011, there was a lot of mortality in the under 5s, and one of the reasons was that when you were positive that time, it always meant that you have to formula feed. So being positive was always equals to formula feeding. Women were never allowed to breastfeed when they were positive. And remember, research was still being done, and a lot of research has been put into this PMTCT. That's why I say it's one of the protocols that are very close to my heart, because a lot of research has been put and results are being seen, because there's a huge difference in terms of mortality when between now and when women were only told to formula feed when they were positive. There's a huge difference in terms of the mortality. It has improved. Like, that rate is very, very low. And the reason why they were the babies were dying is because when you formula feed, remember, the baby does not get the IgA antibodies from the breast milk. So those kiddies were dying because of opportunistic infections. They were dying because of diarrhea, because of TB, like chronic diarrhea, because of TB, because of pneumonia, because of meningitis, and other infections. So once women were allowed now to start to actually breastfeed, even though they are positive, there was an improvement, like a huge improvement. So that number now, the mortality in the under 5s has reduced like significantly. So at this point, the point that I'm trying to make is there is no woman that should be, or there's no mother that should be forced to formula feed just because they're HIV positive. We want them to be either here or here. Yes, we would love them to exclusively breastfeed, but this one is better than that one. So the mother needs to decide and stick to the agreement. If the mother says, okay, I will breastfeed, I will try by all means to exclusively breastfeed, it's gonna determine the drugs that they're gonna be given and how long the baby is gonna be on the prophylaxis. By definition, exclusive breastfeeding means that the infant is only gonna be taking the breast milk and medications only, no other thing, not even water. Remember, there's no such thing as a thirsty infant. They need water, because like breast milk is like 90% water. So if the infant is thirsty, it means that they just need more breast milk because there's water there. So this becomes very important. We said that a high-risk infant should be on dual therapy of AZT, Z-ovotin, and NVP. And then there's a high risk. You can have a high risk infant that is exclusively breastfeeding, or a high risk infant that is exclusively formula feeding. If the high risk infant is exclusively formula feeding, they should be on AZT for 6 weeks and NVP for 6 weeks. This is according to the 2019 guidelines, which is the most current guidelines. So I call it the 6-6 rule. So high risk infant, formula feeding, 6-6 rule. 6 weeks AZT, 6 weeks NVP. A bit of a complication comes when a high risk infant is breastfed, because remember, there is a chance of transmission in the of the HIV in the breast, even though it's said to be minimal, but there's still a chance. So with them, yes, we said AZT and NVP. But for how long? The AZT is 6 weeks. The NVP is 12 weeks. Is 12 weeks minimum. When I say minimum, I mean that there are conditions or situations where you have got to go beyond 12 weeks. So the 12 weeks is minimum. Now, when do you go over 12 weeks? It's when the VL of the mother is more than 1,000. So mom is not virally suppressed. So if you get to 12 weeks, the infant is on NVP, you get to 12 weeks, but when you get to 12 weeks, the mom's VL is still more than 1,000. You continue until the VL of the mother is less than 1,000 copies per mil, or until 4 weeks post cessation of breastfeeding. Right? So that's why I was saying the issue of feeding needs to be communicated to the mother, and she needs to understand why she must choose a method of feeding and stick to it, because it will be very disastrous for a mother to say, I'm gonna formula feed, and then later on she changes, and I mean vice versa. Because if you can see, as long as they continue to breastfeed here, their NVP is longer, is double the NVP that is given when you are formula feeding. And also it continues if the VL is high. So it will be very disastrous for a mother to decide, okay, I'm gonna change now from this method of feeding to another method, especially without communicating with the healthcare provider. So that's the high risk. What happens with the low risk? First of all, we know that the low risk infant should be on monotherapy, which is NVP. That NVP is 6 weeks. That NVP is 6 weeks. So the next question is, how often should we have these babies tested? That's HIV testing. So at birth, they need to do a polymerase chain reaction, which is PCR. That's at birth. And the reason for this is just to determine if there has been an transmission in utero. And then the next PCR should be at 10 weeks. The next PCR should be at 6 months. And then an age-appropriate HIV test should be done 6 weeks after breastfeeding. 6 weeks after stopping with breastfeeding. So the mother must stop breastfeeding, and then after 6 weeks she must go and have the baby must go and have a HIV test. And this HIV test can either be a PCR or it can be an ELISA, depending on the age of the baby. And then at 18 months, So the new guideline says that, this 2019 guideline says that at 18 months, all infants should be tested. They are babies at that time, no? I think infants is up to what? Is it up to a year? I think so. So at that time, at 18 months, they should all be done a HIV test, whether they are exposed or unexposed. The only group that will not be tested are those that have been confirmed to have the HIV already and are even probably on treatment. So, which means that if a baby remains PCR negative, they will be done this test. But if at some point the PCR becomes positive and then it's been confirmed that they are positive, then they will be started on treatment. So there won't be a reason for them to be tested when they get here, right? So that's how often should they test, and this is how long should they be on prophylaxis, and what method of, depending on what method of feeding are they on. So guys, at this point I don't think I'm leaving anything out, but if you feel that I've left something, just send me just comment there and then I'll look into it. So guys, this is a very important guideline, and when you, during internship, most of the decisions, especially in peds and all these other critical places, most of the decisions are made for you. But during ComServe, you will be thrown into maternity. You will be thrown, and when you are in maternity, you also take care of the infants that are delivered. So this has got to be like on our, at the back of our hands and on our so we just need to be on it so that we can understand, we can know exactly what we are doing, and so that we can help these babies and reduce their chances of getting the infection and become positive the rest of their lives. So maybe on another video I will need to talk about what happens if they've got they are confirmed positive now. What happens when they are confirmed a positive? What drugs are they started on and that type of thing? That's like your, I mean, pediatric antiretrovirals. Yeah. So thank you so much, guys.